My name is Dr. Mike Ruma. I'm a maternal fetal medicine doc. I'll tell you a little bit more about that. I'm joined here by LaShea Haynes. I think you know her. We are really thrilled to talk to you today about a hot topic. We're going to spend, I'll tell you just how the morning is going to evolve. We're going to spend about 40 minutes talking from a doctor's perspective on antenatal corticosteroids. What are some of the controversies currently today? How should we be approaching this? And I hope you enjoy it. I'll take some questions in regards to my presentation, and then from there, LaShea is going to give you a nurse's perspective, and really I want her to inspire us because nurses really do make things happen. I go to a lot of doctor organizations, a lot of doctor meetings. I have to say they're pretty boring. Don't tell my friends, but you really are an organization that is direly needed in America today. We need to make change in the way we take care of moms. I grew up as a son of a doctor, a grandson of a doctor, and a son of a nurse mom. I was always taught to make sure to take good care of the nurses who take good care of us. And I really want to just share my thanks as a physician for what you do to help my patients every day. All right, so let's get started. So we're going to talk about steroids. I told you a little bit about the breakdown. I'm going to spend time talking about fetal lung development. We're going to talk a little bit about history, summarize some clinical studies because we love science. Talk about what our current recommendations are today and some of the controversies. Then I'm going to hand it over to my colleague, LaShea, who's going to acknowledge this controversy, find out how we actually can improve it, look at evidence on ways we've already done that through standardization protocols, and really then move on to what I'd like us to take away from today is we need to implement a new quality metric, which I'm going to spend some time talking to you about today. When you listen to people that are lecturing to you, it's always good to know who's speaking to you. First and foremost, 99% of my day is spent taking care of complicated pregnant women. I do that at Perinatal Associates in New Mexico. I also love working with industry because it helps me really be the best doc I can, understanding what's out there and what's growing and what the research is going to be. I do that with Hologic, I do that with Obix, and I've done a lot with Philips Ultrasound. I grew up in Nebraska. I'm really excited that I went to the same school that Jonathan Webb, your CEO, went to. I did undergrad at Notre Dame. He did his MBA at Notre Dame, so we got some good ties here with Notre Dame. Did my fellowship in Chapel Hill, North Carolina, and I've worked in New Mexico for 15 years. A little bit about why I'm passionate about protocols and standardization is I work in this state, New Mexico. New Mexico is one of the most rural, fifth largest landmass in the United States, and we have had to spread out offices all throughout the state to take care of complicated pregnant women. We took care of 8,000 last year. We're on track to take care of 10,000 individual patients this year. We have 5 docs that work for our practice. We have over 130 team members, a lot of nurses, 17 nurse practitioners. We utilize these nurse practitioners helping us take care of patients in the hospital, in the outpatient setting. I have 3 that do psychiatric mental health. I'm beyond proud about that. We have 4 of them that do diabetes care in a dedicated fashion. I could not do my job without the huge work of the nursing staff that support us. If you ever want to make a trip to come visit, or you're looking for a new employer, we definitely are looking for great people. I always make a pitch about New Mexico. New Mexico is a unique state. We have the world's largest international balloon festival. It's the first 2 weeks of October. If you've never been in a hot air balloon, definitely recommend that you try it. In our state, we're absolute professionals at it, and it's a really gorgeous event. Okay, let's talk some science. Ready? So, antenatal corticosteroids, I know you're familiar with this topic. I mean, it's probably the most effective therapy, most influential therapy in perinatal medicine. It's definitely helped thousands, hundreds of thousands of infants. It still is shrouded in a bit of mystery and uncertainty, and we need to talk a little bit about that today. So, why do we use this medication? Respiratory distress syndrome, I know you guys see this. The baby stops breathing, has difficulty breathing, not oxygenating well. RDS is really caused by preterm birth. It affects half of babies that are extremely preterm, under 28 weeks, a little bit less as you get to 32 weeks. And if you like birth weights under 1,500 grams, you have about a 50-50 chance you're going to have complications of RDS. Why does it happen? Surfactant deficiency, poor lung development. It takes five stages of lung development for our baby's lungs to actually grow to fruition. And it takes until age 2, when the kid's actually out, for the lungs to be fully mature. We give steroids because it stimulates 2 types of pneumocytes. It improves surfactant production and release, which acts and allows the alveoli to open and close more smoothly. We know as steroids go down, so does the effect and the benefit of that steroid. This stuff was identified a long time ago. 1972 in pediatrics, a guy named Graham Liggins did a study first in sheep and then rapidly changed that to a study, a randomized controlled trial in women. He gave betamethasone, the same medication that we use today, as a randomized trial, gave that as the intervention, and then in the study arm, a placebo. And they looked for how did it affect RDS. When you look at this very old, this is like stolen off of actual piece of paper. I love that it looks kind of not perfect in today's PDF world. You look at 2 and under 7 days, 33% RDS rate in the placebo group versus 3.6% in the actual treatment group. Giving steroids 51 years ago is beneficial to the pregnant woman and her unborn child. But even at this point in time, we actually knew that there was a limitation to this medication based on the timing. Professor Liggins said, you know, RDS definitely occurs less in treated babies, but he also said that we do need to do some more study about this. This is not an understudied area. There are at least 24 different studies that show that antenatal corticosteroids are of benefit to the preterm fetus. And so this is why you have a massive statement from the American College of Obstetricians and Gynecologists. And I want to share a little bit about where we've evolved over the last 5 decades. This publication has seen a lot of change. You can see it's been changed here 5 different times just in the last 5 years. Why is that? We're still refining, learning, and understanding the benefits and some of the potential cons of this particular medication. ACOG says this medication is probably the most important therapy we can do antenatally for moms and their unborn child. What have we learned about steroids? We should be offering it to moms at risk of preterm birth within 7 days. If they are 24 weeks and 0 days to 33 and 6. We should be offering it to moms who are 34 and 0 to 36 and 6. That's based on a study called ALPS, Antenatal Late Preterm Steroid Study, performed by a friend of mine, Cynthia Giamfi-Bannerman. Additionally, peri-viability, 22 weeks, 0 days to 23 and 6. If the patient desires full intervention, if the weight is compatible with life outside the womb, we need to have a discussion if we think delivery is going to happen within 7 days. What is so important with this within 7 days? Why do we need to pay attention to this? We know that when you give steroids to a mom, if that kid is born within a week, you are going to have a profound impact on whether the kid goes to the NICU, dies, has RDS, has any type of systemic infection, has a bleed in their brain or a bleed in their gut. Steroids are highly beneficial. The timing, though, is what's critically important, and we're going to spend time, and LaShea is going to spend time on why we need to refine our efforts on how do we give and who do we pick to give steroids to. The farther you get away from those initial 2 injections that you give 24 hours apart, they cease working. It gets worse and worse outcomes. On day 7, 9, 14, 22, the farther you get away from those, there is really limited to no benefit. And we learned that in Liggins' initial study, but it was 50 years ago. What happens in medicine? We forget stuff, right? We don't pay attention. And then we have forces that also push us in directions, and we'll talk a little bit about that. How are we doing? I mean, are we doing a good job? Do you guys, when I say give that lady steroids, do my nurses, they give them steroids and then she delivers perfectly in 7 days? This is a study from Canada, from Razaz. Yeah, do you guys think we do steroids well? Yes? Do it great. Well, I mean, you see in the slide, right? I'm already cheating. 23% of patients get optimal timing of steroids, that 2 to 7 day window. So we need to do better. This is specific by type of patient. Is she abrupting? Does she have high blood pressure? Is she in preterm labor, which we're going to talk about because that's the most common presentation to obstetric triage, most common cause of spontaneous preterm birth. The red is optimal. You can see it's not great. The green is not optimal. Look at asymptomatic pregnant people. Should you give a woman who is not complaining of anything steroids? Probably not. Listen, gain information, use tools, develop protocols, put them to purpose, and maybe then we can fine-tune and make this better. My society, the Society for Maternal Fetal Medicine, I'll tell you, don't tell them. Are there any SMFM people in here? Oh gosh, uh-oh. Okay. You guys are way more fun than SMFM. I'll go on record saying that. They put out an excellent statement that allows us to refocus our efforts. And they want us to better optimally time antenatal corticosteroid administration. This came out last year, so if you haven't read it, don't worry. We have a lot of copies at the booth, and we'd love to pass them out to you. But I think you need to focus on this a little bit, and all people that are taking care of pregnant people need to focus on this. We know steroids are best given within 7 days if we need that kid to come out in that time frame. Studies show we are only effective at this 20 to maximally 40% of the time. Can we do better? Why are we doing poorly? Joint Commission, perinatal care quality metric, PCO3. Anybody hear about that? Did you guys implement it in your programs? Did you track it for a decade? Did you achieve 100%? The United States retired this metric because we were so effective at just giving steroids to essentially every preterm woman who came in for anything, steroids. I think you guys remember this. The metric itself, propagated through JCO, really incentivized us to just give this medicine liberally. We know, though, we don't time it correctly, but what we're learning, which is important, why I'm so excited to talk to all of you, is that there may be potential harm to this medication, and we're learning more about antenatal steroids. They're profoundly beneficial, but there may be some evolving information that potentially if I give steroids and that lady delivers at term, greater NICU admission rates, small for gestational age babies, and maybe neurocognitive delay or behavior disorders. These are a handful of the studies that have been published in recent years in the last 4 or 5 years. This is an evolving field and something that we all need to pay attention to, and there's not a perfect answer about this yet. This all started initially with this major study in JAMA in Finland. They looked at children, because in the United States, it's hard for us, we all have 20 different versions of electronic medical records. We can't track stuff well. In Europe, they can do this extraordinarily well. Mom and baby are tied frequently. And so they looked at kids that were exposed in utero to antenatal corticosteroids from birth to 9 years. How did they do, and did they ever have any diagnosis related to mental or behavioral disorders? Just general terms of that. Almost 15,000 in utero exposed children, 45% born at term, 50-some born preterm. So about 50-50. We're not accurate at least half the time. This is where it gets kind of interesting. If you give a mom in preterm labor or PPROM or preeclampsia steroids, but she doesn't deliver until term, you can see that adjusted hazard ratio 1.5, greater chance if the kid does not deliver in the preterm setting of having a neurocognitive outcome that we may not want for that child. If the kid got it preterm and delivered preterm, there's no effect. Followed up to 12 years of age. They got more specific. Now we're not going to lump it into a general category. We're going to say speech and language, scholastic skills, motor function, pervasive developmental disorder, epilepsy, hearing loss, etc. What did this one show? Same phenomenon. Now, it's not massive numbers, but the overall cohort, 3 versus almost 6%, so we're almost doubling the children that have some of these diagnoses that we probably don't want them to have. And it is predicated on an early exposure to steroids preterm when the kid actually comes out at term. That's the phenomenon that we need to think about. This is in Finland. This study comes from Indiana University. And there's several from this group. David Haas is the researcher. Very interesting as well. Not all about mental and behavioral outcomes, but about does it cause like excess complications for the neonate? Do they go to the NICU? Are they too small? And do they have respiratory disorders because we revved up their lungs in utero, but then the effect didn't last, and maybe we caused something where the kid doesn't perform as well when they come out at term. In this study, a huge number of folks, 5,000 plus pregnant people, they got their steroids around 32 weeks, most of them. The mean gestational age was 38.9. Most, more than half, delivered term. It's a little small, but you can see in the betamethasone exposed group, 12% versus 6%, double statistically significant, higher rates of NICU if you give a kid preterm exposure to steroids and they make it to term. I've actually had a parent ask me this recently. I've not had it frequently, but a dad was like, you know, my wife came in for preterm labor, her fetal fibronectin was negative, and the obstetricians gave her 2 doses of steroids. Is that good for my baby? So I think you will start to listen and hear this more frequently. Parents read. They're interested in the outcomes of their children. They know we only give them a handful of medications in pregnancy. I think we will, and this is why it's important for us to think before we act, particularly with this medication. I'm not saying that we shouldn't give it out if we think the baby's going to be born, but just understanding that there may be some risks. So this is US data, and there's been great interest in this, and this is why the SMFM organization has put together this desire for a new quality metric. They tell us that there may be some adverse impact to the way we're doing things currently. And maybe we need better tools to determine who's going to deliver. I'm going to say we actually probably have some tools, and LaShea and I both are going to talk in detail about those tools currently. We're also going to show you that we're probably not using those tools that we actually have. So better prediction tools are needed to support clinicians. I think that's obvious. And what SMFM is saying, they want us to, as clinicians, to thoughtfully evaluate the actual risk of preterm birth within 7 days prior to giving that lady 2 shots of betamethasone. They, in the article, say, avoid administration of antenatal corticosteroids in women whose risk of preterm birth is low. Who is that? A lady who's asymptomatic. I have some older partners that love to admit people with short cervixes of like 6 millimeters. You guys have anybody who does that? Okay, I'm going to show you some information later. I'm going to fly home tonight, and I'm going to assume the hospital service along with clinic in our downtown office. And I'm going to have several folks that have short cervices, and I'm going to evaluate them. I'm going to do a test, and if the test is negative, I'm going to ask them to go home based on data I'm going to show you. Whew. Wow, we do not get, you don't get that exactly from a physician crowd, but I'm glad, yeah. They must really like rounding. I love rounding, I love interacting with patients, but in the outpatient setting, it's just so much more fun in clinic, you know. They're home with their kids, they're working, they're taking care of their families. You know, we need to keep them out of the hospital. Additionally, SMFM says, you know, if a patient comes in with preterm contractions, use a laboratory test. If the fibronectin test is negative, do not give them steroids. They said facilities, this is from SMFM, facilities need to track the rate of optimally timed administration rather than the PCO3. PCO3 has been retired. If you're still tracking it, you're not obligated or required to. What LaShea and I would like to ask you to do, and she's going to really focus on, I want us to try to put this into practice across the U.S. SMFM, Society for Maternal Fetal Medicine, encourages facilities, all of you in the entire United States, please develop pilot quality improvement projects to figure out and improve the way we optimally give steroids. We're being asked to do this. This is the new metric they would like you to do. The bottom denominator, any preterm birth 24 and 0 to 33 and 6, over the properly timed patient who received steroids and then actually delivered within 7 days. What do we want to achieve? 100% performance. We want to see this metric rising over time. I don't care how you do it. You guys are the smart folks. You put these pilot projects into purpose. Go for it. Show us how to do it. Because, I mean, honestly, I'm waiting for our organization to figure out how to do it. The term births with exposure to steroids earlier and preterm, that's the denominator in this new one. The number of patients in the denominator who gave birth at term. We should see this metric go to 0, hopefully. And ideally, then, maybe we don't have to worry about some of these adverse outcomes. All right, we're going to hustle up here. So how can we improve this? You know, I mean, we have all these different things that we evaluate, and LaShea is going to touch on this. You know, what tools, you can just imagine what you have done in your own organizations today. It's 2 in the morning, 26 weeks, G1, she's contracting, it looks very real. I mean, do you pull out some complicated thing like this? Who has an algorithm for preterm labor in purpose today at your hospital? 1, 2, 3. There's 300 people, 250 people in here. We got 0.5% of you have some purpose and way to evaluate things. We definitely have to change that. Why do we want to change it? Number one thing that we do to patients, we check their cervix, right? That is not highly effective. If they're 0 to 1 centimeters, only 16% of those patients are going to deliver in a week. It's not a good predictor. Don't rely on the digital exam. Yes, you need to do it. I'm a big fan of the old-fashioned physical exam. Use tools. If I walk into your emergency room, I'm not going to tell you how old I am, but if I have crushing chest pain, indigestion, I'm sweating and my arm is going numb on the left-hand side, what are the 2 things I'm going to get? EKG, and what lab? Why do we order troponin? What's unique about that test? That test has an incredibly high negative predictive value. Do you take a patient for a catheterization of their heart if the troponin is negative? No. Do we admit women that have a bunch of things that are negative to the hospital and do a bunch of things to them because we think something's going to go on? FDA-approved test, yes, it's been around for 30 years. It still has tons of evolution and articles written about this. It has a high NPV. Just putting to purpose a single test could reduce the rate of exposure of steroids. It also could identify high-risk people as well if you put things together, symptoms, maybe an ultrasound, and an abnormal positive fibronectin test. That's really where you achieve the highest PPV. What do we see actually happening today? Great stuff, right? This is a study from the Netherlands. They implemented a big protocol. This is before the protocol. Cervical length greater than 30 millimeters. Is that good or bad? It's pretty good, actually. Really low chance of delivery. 23% of those women got steroids. 10 to 30 millimeters, an equivocal cervical length. How many of those folks, they had a negative fibronectin? How many of those folks got steroids? 70%. Completely unnecessary. We should not be giving group 1 or group 2 steroids. When you guys do cervical links, hopefully you're all trained to do them. Does this look normal to you? How many pictures? When you see a doc or a radiologist or an MFM or an OB resident go in to do an ultrasound of a cervix, how long does it take? Seconds? Seconds. How long should it take? 3 to 5 minutes. What occurs in the, every 2, 3 minutes? Yeah, 0 minute, 1 minute, 2 minute, 3 minutes we're watching. U-shaped funnel, you see a big bag of water in the cervix, and she's 5 millimeters dilated. This is high risk. I know this because I do ultrasound every single day. There's a lot of disparity and a lot of randomness around this particular thing. So if you want to do it, incorporate it with both tools. Fibronectin, if negative, in a really extremely short cervix, also tells you don't do anything to the patient. And we're going to talk a little bit more about that because my friend, Dr. Janfi Bannerman, did a study, the utility of fetal fibronectin in asymptomatic singleton and twin pregnancies. If the cervix is under 10 millimeters, this is crazy short. Like, there's only a centimeter left of that cervix before that bag maybe starts to see the outside world. If you do a fibronectin and you follow the test result, what does it mean? The NPV in a setting of an extremely short cervix, we like ultrasound, I love doing ultrasound, I'm an MFM. If the fibronectin is negative, 0% of those women delivered in 7 days. 0% of them delivered in 14 days. What does that tell you? Give them steroids, give them some mag sulfate, put an IV in, fly them to see me. We really should think about this. You guys are right there at the bedside with the person. Maybe you guys are actually collecting these tests. I wish we all would just have nurses collect, send it, get the test results, call the physician or the midwife with the results and say, I have this and I have that, and what's the disposition? That would probably be better than total randomness. So I think we're trying to make a point this stuff is useful. We're going to slowly work towards the end here. This is an article by Sean Blackwell, former president of the Society for Maternal Fetal Medicine. Are pregnant individuals, when they walk into obstetric units across the United States, how are they being treated? How's my wife, your daughter, your cousin, when she wanders in to be at Indiana, where I did college, Creighton University in Omaha, Nebraska, University of North Carolina, where I did fellowship, Albuquerque, New Mexico, just pick the place. This is a huge study, 5 major insurers looking at, were women evaluated equitably? Did we do a good job? We triage pregnant people. Most of them are discharged. The great majority of them deliver at term. That's naturally what's going to happen. The high-risk patient, the 20% in red, that actually were evaluated in your unit, what happened in 72 hours? She came back and she delivered. And she had a preterm infant. How did you evaluate her in your particular unit? This study says 80% of people had nothing done to them. EKG and troponin, fibronectin, maybe that's all you can do, wonderful. If you can combine fibronectin and ultrasound, great. We're not taking good care of pregnant people in the US. This needs to get out here. Can we make a difference? I really think we can. I like talking about this. I like, honestly speaking, to nursing staff way more than physician staff because you guys have energy and initiative and you actually have babies for the most part. This is a study done in the northeast corner at an organization called Trinity Health, and it was presented at ACOG in 2019. They took a preterm labor algorithm. I don't care which one you use. LaShea is going to talk a bunch about algorithms. But can we make a change by just telling our practitioners, our nursing staff, this is the way our organization is going to do something. So they put this algorithm, this came from the March of Dimes Preterm Labor Assessment Toolkit, and they put it into use. They evaluated 1,800 plus women. And then they looked at a bunch of outcomes. Take a look at this. Sterile speculum exam. When you see a patient in preterm labor, do you do a physical exam on the patient? Half of these people pre-implantation had no speculum exam. How do you collect gonorrhea, chlamydia? How do you collect a fibronectin test? How do you look at the cervix? You can immediately tell something's going on by just looking in there. Oh, I see a butt. C-section. I see meconium. You know, I mean, I see a placenta. You can learn a lot by looking. Old-fashioned is good, but use the other things. Digital exam was the next step. They improved their digital exams. Look at how many people had a follow-up digital exam. How do you determine if a woman is in preterm labor? Cervical change. Painful contractions with cervical change. How do you know she changed? They never checked them again. This is why you need protocols. You have to enforce follow-up. Fibronectin use, 23 to 36%. That's great. Ultrasound use didn't change. Why is that? I like working 8 to 5. Radiology doesn't really know how to do vaginal ultrasounds very well. My sister's a radiologist. She'll attest to that fact for me. So they didn't see any difference there. How did their babies and their exposure to things do? So this study was done, honestly, before the debate about antenatal corticosteroids. 19 to 16% statistically significant reduction in maybe a medicine that has some association with neurocognitive delay in infants if they're not timed correctly. We can make a difference if we actually try. They decreased their rate of maternal admissions. I told you I love rounding on moms, but I ideally try to keep them out of the hospital. And then interestingly, they had fewer deliveries within 2 weeks with a protocol. And this is not the only study that's shown this. There's a study by Bergella that also demonstrates this. Maybe if the woman is contracting, she's dilated 1 or 2 centimeters, she has a positive fibronectin, maybe you're able to do a cervical linked ultrasound, it's also bad. That woman we give steroids to, mag sulfate, antibiotics as indicated by the GBS, that might actually have an effect if we limit our interventions to that highest risk group. This study, very, very interesting and profound, and LaShea is going to follow up on why we need to put this to task. Protocols work. I'm going to ask you guys to keep studying the literature. I want you to be thoughtful in the way you evaluate and manage and talk to your clinicians before we decide to do things to patients. I'd ask you to use the tools we actually have in purpose. We're going to bring better things to the market. That's going to happen, but it takes time to get there. We have tools we can put to purpose today. Follow a protocol. You don't have one, so you need to listen to LaShea and put it to task, and then trust the test results. Our professional societies want us and are empowering us to do this. ACOG asks me as an obstetrician, use checklists. If you're a midwife, ACNM wants you to do this. AWHONN wants you to implement checklists and standard order sets in your organizations to make it easier and better, and I'm going to rely on you to help us do that. Steroids, by far, the most important therapeutic in perinatal medicine. We know the indications. We need to continue refining them. We're still learning about this. What we have learned in the last 5 years, is that the timing is critically important for the benefit, but also to avoid the adverse outcomes. I love Atul Gawande. If you've never read this book, I make no proceeds from talking about him, but I have had a chance to meet him at the ACOG National Meeting. I've changed numerous things in my own medical practice because of this book, Checklist Manifesto. I love this line. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists. We pay little attention on how to make them fit together well. Your organization has an incredible ability to do this, and we're relying on you. If you have any interest in listening to me, I know you're going to have interest in listening to LaShea, maybe again at your own future organization. We can do it virtually, we can do it in person. Take a quick snap of this QR code. We would greatly appreciate, especially since you guys all ran in the room like crazy, if you would throw us your emails and your name, we'd love to reach out to you and provide education, give you a recording of my talk and LaShea's talk, and hopefully together we can actually make a change. Really, really appreciate your attention. Thank you very much. If there's any questions, I'll take a few questions, and then I want to hand it over to my colleague, LaShea.
Do you see any difference or the adverse effects increase when you do a repeat course of steroids? Because we do that a lot also.
Yeah. We know that steroids, when this first, it took Liggins in 1972 to show us that this functions. It took until 1994, the National Institute of Health told us, they basically put a mandate, you should give steroids. Then over the next decade, we said, oh, well, more is better, right? Like, let's just give them steroids every week because we don't know when she's going to deliver. What happened with that is we actually shrunk fetal heads and caused microcephaly. And so it seems to go away, but it takes years to go away. So your specific question about the neurocognitive studies, there is not a focus on that. Though the studies included both single course and rescue course steroids. One benefit of recent that is not published yet, but at SMFM in February, Dr. Giamfi Bannerman presented an abstract on just a single course of antenatal late preterm steroids from 34 and 0 to 36 and 6. In that cohort of women, we did not, if those people didn't deliver within 7 days, she did not see harm. Educational development levels were fine. This likely is confined to the extreme preterm infants at 24, 26, 28, at least up until 34 weeks. That would be the area of great concern. And interestingly, based on the studies, is probably the most common time we give steroids.
Hi, Dr. Ruma. Thank you. This was a very enlightening topic. Definitely will be reading those articles. So the question is, with the cohort with 5,000 women, what was the percentage of infants you said that had the neurocognitive disorder? What percentage out of that?
The Indiana study looked at TTN, NICU admission, and small for gestational age, and it went from about 6 to 12%. These are small rates, but essentially the odds ratios were about twofold.
Okay.
The Finland study, the Scandinavian study, was the one that looked at neurocognitive outcomes. That one also saw almost a doubling of those outcomes.
And the follow-up question was, with the NICU admissions, what were the problems? I know, I think we...
TTN, transient tachypnea of the newborn, which is kind of interesting, right? Mm-hmm. We give steroids, which help the lungs, but maybe at the end, somehow we don't understand why, but TTN was the one reason for admission.
Okay, thank you.
What are your thoughts on steroids in the pre-viable, like 23-week age infant? Our neonatologists are pushing it.
Well, yeah, we, great controversy, which has actually caused some arm wrestling between MFM, myself, and like an obstetrician who was like, what? You're giving a 22 and 3 lady steroids? It depends on the weight. Definite want good ultrasound, ideally MFM, NICU, OB, midwifery, all talking to the patient. What does she want? What are the outcomes? And if full intervention is desired and the weight supports that, if the fetus is 300 grams, I don't think any of your hospitals are having those babies survive, but we have had 22 and a half weekers that are 355 grams, 375 grams that actually have survived and had good outcomes. It is rare. It requires some very good counseling and conversation that nursing staff should be well involved in, and you should be sucking those. It should not just become like this is, we're going to lose opportunities. You only have 2 chances currently to give a mom steroids. And so why burn it at 22 weeks if we really don't think, if that, she should be dilated 5 centimeters, have a profound reason, maybe early broken bag of water. Those are the settings for periviability.
Did you find, working in different facilities, I found that some places have a cutoff of like 34 weeks or some have 36 weeks. So like you have somebody who's 36 and 5 and you're doing it 24 hours apart, then the likelihood. So I just wanted to see what your thoughts are on that, what the cutoff should be or where they're leaning towards.
ACOG, SMFM, ACNM, Cynthia Giampi Bannerman, Antenatal Late Preterm Steroid Study published in the New England Journal of Medicine, 34 and 0 to 36 and 6. If that patient's going to deliver, 37 weeks and 0 days is, quote, term. We know respiratory distress rates are 5% at 37 weeks. There's actually a study in England called the Aztec study, antenatal steroid before elective term C-sections. 37 to 38 and 6, they gave women steroids. It reduces RDS by 50%. Small, 5 to 2.5%, 2.5 to 1%. There is a continuum of benefit, so in those late pretermers, which is the most common group we're seeing, we want to give them steroids, and we're gonna be good at the timing because we know they're gonna deliver shortly.
Thank you very much for your lecture. My question is, being that steroids are given in preterm, the rescue dose of steroid, how does it affect those pretermers that already had the steroid given? How does that help them to prevent them from going to the NICU?
Yeah, really in the same fashion. That initial course of steroids is given, say she comes in at 25 weeks, we work her up for preterm labor, we give her steroids, and we thought she was going to deliver. She comes back at now 28 weeks, 3 weeks later. This is the exact scenario. We should give a patient, offer them rescue course. She breaks her bag of water. 80% of women with PPROM are going to deliver within 1 to 2 weeks. Give her the rescue course. It has the same benefit, reduces RDS, reduces interventricular hemorrhage, necrotizing enterocolitis. That rescue course is super important. Same mechanism of action.
Just for the patients who have the PPROM, if they don't come in with signs of labor, but let's say they're 30 weeks pregnant, you don't know if there's going to be signs of infection or fetal distress, when would you suggest, because right now I feel like the providers want to go ahead and your preterm, your rupture, they just want to give you the steroid automatically. But then with thinking about that timing, is there a special way to think about it?
Ruptured, preterm premature
Yes.
rupture of membranes, broke her bag of water, she's 26 weeks, and we're talking timing of steroids?
Mm-hmm. Early.
I would give them, I would not try to time this setting in the setting of PPROM. The great majority, 8 out of 10 women are going to deliver in 14 days, and a huge percentage of them are going to deliver within a week. So I definitely am giving that patient steroids. If she makes it past 7 days, and gets active, lots of bleeding, concerns, laboring, repeat the steroid dosing. 2 intervals, 7 and 14 days in the literature for rescue. Either is acceptable. If that was my baby and that patient, you think that kid's really coming out at days 8, 9, 10, give her the rescue dose after 7 days. All right, thanks guys.
Good morning. All right, we're going to jump right in and get to the second half here. I thought that was interesting how Dr. Ruma had mentioned having something in common as far as the same school with Jonathan, and we kind of have that in common. Jonathan and I went to the same high school, and so, this room is just a little tight. Next year I told him, we want something a little bit bigger. I'd hate to have to use that 9th grade picture. I'm originally from Philadelphia, so like I said, yeah, we went to the same high school, went to Jeff and Widener, and then I moved to Georgia. So I've been in Georgia for about 23 years, so definitely a Georgia peach at this point. Love AWHONN, very, been a member since I became a nurse 27 years ago. What else? I am the editor of AWHONN Healthy Mom and Baby magazine, so you may find me there at that booth tomorrow. Today, you will definitely find me at the Hologic booth, so if you have some questions, myself and Dr. Ruma will be there to talk to you about quality improvement and getting some projects going. We also in our magazine, if you didn't know, that we do have a consumer-based magazine. We have some great articles in there about preterm labor and just even some light education about FFN and for patients to be able to have that shared decision making and kind of talk to their doctors and ask if they qualify maybe for the test. I am also a staff nurse. I work in an LDRP and I 2 days a week I do take care of patients. I am a staff nurse in a facility. We do about 50 deliveries a month. And so very excited and enjoy doing that. So that is me. And I've been speaking for Hologic for about, 15 years. It's something that I use, right? It's a reliable test. It's something that we, count on for our babies to get them transported, and, it gives us really valuable information. So it makes this really easy for me to be able to do. So happy to be here, and we will get started. So the purpose of my course, we're really going to kind of talk about some of the preterm labor current stats. We've both been mentioning March of Dimes, and they give us such really important and vital vital information and peristats. So we're going to kind of talk about where our stats are, identify areas in working that need improvement, right? Because that's why we're here. We're all here at the AWHONN conference. Homework, right? We're going to take our homework back and see what improvement projects. Every year, this gives us our aha moments. I've been to the last 17 conventions in a row, so I'm a little addicted to aha moments, right? I like a little bit of a challenge. I'm not into sports. This is my challenge, right? Quality improvement. That's kind of what I see as my sports and what gives me my drive for that following year. And then evidence-based research. I am an advanced practice nurse and a board-certified clinical nurse specialist. And what do? We bring best practice to the bedside. So again, these are the kind of things that fill my cup when we start talking about evidence-based, enhancing standardization, and quality improvement projects are really just my language. You see how I'm already starting to get excited about it. And so hopefully I have some of you that are going to be energized and ready to take on a new quality improvement project. And we'll get to talk about that at the end and or at the booth. Some of you may be in school looking for a poster project, really looking to grow. Even some of your nurses that are at work that are just kind of dying to do something, want to get involved. Maybe this would be a great way to get your charge nurses involved and have them in some kind of quality improvement project, something they can work on. Maybe you do a one-day conference at your facilities every year. This would be a great way to have something to talk about. Your local chapter meeting. This could be a great way to present something at your chapter meeting or your section conference. See, I could keep going of ideas and where we can take this information. So we're going to go ahead and get started. So again, like I said, talking about March of Dimes. If you have not been there yet, marchofdimes.org/peristats, Peristats. It really gives you a wealth of knowledge for those of you that are like travel nurses. It's really nice if you're getting ready to go to a state. You pull it up, they have an equity calculator there, and it'll give you your rates. So we're going to start with just the United States. We've got a D+, and we're worsening. We had a C, right, with C- or something last year, and so yeah, now we have a D+, so we're pending in the wrong direction, right? So we're all in the right place so that we can improve outcomes and figure out what can we do to maybe improve some of that. So again, the average rate is about 10.5%. Does your facilities, just by a quick raise of hands, are you using some kind of protocol? I know we talked about that earlier. It was just a few people, right, that had some kind of preterm labor protocol. Okay, so just a few. All right, and so again, this is some additional information, just kind of looking at our map here strategically of what our rates are. I, as I mentioned earlier, am from Georgia. We are in the South right now, and we see that whole panhandle there has an F, so lots of room for improvement for our people in the Southeast that are here in the room. So in particular, kind of speaking to them, that this is definitely a project and something that we want to take on when we look at those statistics, and even more so, we are in Louisiana, right? And their preterm birth rate there, we can see 13.5%. And there is that, like I said, peristats there, that tools, if you want to take a quick snapshot of that, is how you get that information. And you can get that information on each of your states, and they really do stratify it and break it apart and give you some really, really good information. And so for anybody here that is in Louisiana, hopefully you guys will come and see us a little bit later on so we can really get you guys started in a quality improvement project. If we go a little further here and look at Louisiana by county, we see there in Cato, which is near Shreveport, we have 18%. Almost 19%, and it is each year worsening in that county. So the nice thing about March of Dimes and the fact that they give us this kind of information, it really helps us to know, okay, where are areas that we need to hone in on, like I said, and work on. So if we have people that are here from those areas, even more so, we need to try to improve that and help these moms and these babies. They'll give you additional information on disparity and things of that nature. And really, kind of what all of this tells us, it can really help us when we're looking at this really multiple pathway leading to preterm birth. You've probably seen this often. And so these are all the multiple ways, biochemical, biophysical ways that we can have preterm birth. But going back to what we looked at from the March of Dimes, when it hones in and tells us with counties, we have a lot of the information now that tells us, okay, these counties are living in food deserts, right? So they do not have access to good foods. They have their maternity care deserts, so they probably do not have 10 or 12 Dr. Rumas running around to help them and guide them in the right direction, right? So they're probably lacking MFM, they're lacking OBs and healthcare providers, so they're probably not not being able to get to the doctor as often as someone in a county that would be rich of healthcare providers. Maybe the jobs are not available there. And so I think now we need to start taking that information that we have on the March of Dimes and utilizing that to identify where are the biochemical, biophysical, what is it? Is it the stress access there, right at the bottom, the maternal fetal stress, what we know about stress now, oxidative stress, right? When the body is stressed, it affects everything, and that can trigger preterm labor in itself. So we may have to start really looking at partnerships, right, with public health and the health department, and is it, food drives and, just other, organizations and things of that nature in our counties to see how we can support and kind of help and improve some of those things. Is it infection? We talked about lack of, OB physicians. It's something, like a UTI. One infection increases risk for preterm labor by 40%. So sometimes it's kind of looking at the low-hanging fruit of what kinds of things we can do. Everything doesn't sometimes have to be so grandiose. And so just paying attention when you have that triage patient and it says, recurrent UTIs, sometimes it's just something as simple as she's been on macrobid for the last 10 years, right? Maybe she just needs some Cipro. So sometimes we have to just kind of take a few extra steps, especially when you look at, again, what state you're in, what is your preterm labor rate, really try to, kind of tease this apart and just look at how can we, as nurses, really make a difference. And so that ties into that evaluation of preterm labor. So again, when you get those patients, they're in triage, they're here for preterm labor, what is really going on? Like I said, is it that recurrent, infection? Are they, if they're missing visits, are you in an area where it's mainly factory workers where, hey, to go to the doctor, they're missing a full 10-hour work shift? And they can't afford to do that, right? So they're coming to triage as their visit for the month. If that's happening a lot in your area, maybe it's we've got to really look at maybe some Wednesday night visits or something, and some kind of plan. We've got to come up and try to figure out what maybe we can do to really reduce our preterm labor rates. And then the reality of preterm labor is 50% of the patients hospitalized for preterm labor actually go on to give birth at term, right? You guys know that we just don't have the space to have people in antepartum. I can remember about 10 years ago where people just moved in, right? We had people that were there for months at a time. They'd do their homework. We had a girl one time that was a hairdresser and she started braiding hair and had clients coming in. It was a nightmare. So we can't have that. We can't have that. And so the reality is that less than 10% of those women actually with a clinical diagnosis of preterm labor actually give birth within 7 days of presentation. And so those are the women that we want to focus in on, right? Those are the women that we actually have space for. And then we won't have to worry about all those fancy things. We have a hospital in Georgia, one of our competing hospitals, and they used to have all this fancy stuff where they had like art on Mondays and they had somebody that did the cello on Tuesdays and, all this fancy stuff. And so, a lot of our hospitals, we can't afford to have all that. And the pets that come in and dogs and Trixie on, Thursdays and things. And so again, if we, did the right thing and have a nice protocol and can identify, you get to stay, you go home, you go home, you go home, and then you see that one patient, one just gets to stay and really kind of focusing in and honing in on her. So our protocols are going to be able to really help us to do that. And so when we look at this slide here, we have a variety of methods that we use, a variety of tools with predictive ability. But what do we see has the most predictability is our FFN testing. So how many people in the room are using FFN? How many people, it's just, oh, that's great. Okay, that's great. Yeah, this has been around for a very long time. Lockwood studies from almost 30 plus years that it works, right? So our FFN testing, and why wouldn't we? When we just look at this is a pretty simple slide. When we look at this slide and we see that that's what's going to give us, right, the most predictability, then, why wouldn't we want to be using that test? And so we'll talk a little bit more about that. And so kind of be asking yourselves that in the back of your head so we can kind of come up with a plan at the end if you're not using it, so we can figure out, because sometimes it's something so small. We'll have people that come over, to the desk and it'll be something as simple as we ordered an analyzer 6 months ago and it just never came. So you think about just, what I mean? It could be something really simple as far as improving your outcomes. So please talk to us. We're gonna, kind of go through this and see how we can really help you to get our FFN testing going, since that's really what's going to be the best in that predictive ability. All right, so how, again, are your pregnant women evaluated in your facility? And when you think about going back to what I said earlier about travel nursing, the other benefit of standardization is that we are getting a lot of nurses are mobile now. right? Do you have people and they're on the move? Nurses are on the move. That could be a hashtag, they're on the move. So, they're just coming to you for 12, 16 weeks. They don't have time to get to learn the personality of each and every doctor and doctor practice. Well, he likes this, and this one just kind of likes to stare at people for 23 hours, and this one over here likes to follow, right? They don't have time for that in the middle of the night, calling people to figure out who likes what. So we need standardization, right? This is actually a picture of my daughter. Right? And so this is acting, but let's say this was real, okay? And so I would like, right, if my daughter was actually in preterm labor, I want her to be able to go to any facility in this room and know that she would be well taken care of because you'd have a standardization, right? When I asked you to raise your hand if you were using FFN, there was about 20 to 30% of the room that said you weren't using it. Well, that wouldn't be a hospital where I'd want my baby to go, right? So we want to fix that. We want this to be by the end that no matter where in this room, my daughter, who would have, if she was in preterm labor, I could count on her going somewhere where I knew, right? Like I said in the beginning, where they're doing, because that's really what makes a good hospital, right? Good nurse. What makes it good is evidence-based. We got to be doing the best, right? And we apply that when we think about our family members and friends. When somebody has cancer, do you want to go to a hospital where they're doing things where it's comfortable, the same that they've been doing since the 80s? No, right? I'm a cancer survivor myself. I had eye cancer. I went to the best. I went to Philadelphia, right? I went to Philadelphia. That was the best place. So people want the best. They want the latest. They want the greatest. They want where we're doing standardized practice. And so evidence tells us that FFN, over 99% effective, that they will not go into preterm labor. And so again, at this point, the question, we should absolutely be using that. And then on to the next thing of our quality improvement of now the timing, right? So if we're not using FFN, we got two projects here of getting you on board with FFN and then getting the time and accurate with those steroids. So we've got some homework to do. That's exciting. That's okay. We're all here to help you. And so we're gonna get you on board. All right, these are some of the options that you have for preterm labor assessment. So we have clinical assessment of the patient coming in, right? What's her history? Some, 50%, if they've had, a history of preterm birth, then okay, we know to keep a closer eye on them. They're gonna be on bed rest. Maybe we're asking them to drink a little bit more water, things like that. We're checking for contractions. We, maybe doing vaginal exams, that kind of thing. But that's still gonna be very subjective information, right? Because if you have somebody that was in a car accident 10 years ago. They played sports and they have an injury in their back. Sometimes they're going to contract, right? Sometimes just having contractions on the monitor doesn't tell us intensity. It's not going to give us a whole lot. So we've got that really subjective data that we get sometimes from the patient. We do have our transvaginal ultrasound. How many people are doing that at their facilities? They have the ability to do that. Well, as Dr. Ruma talked about earlier, a lot of times that is something that's only done between 8 and 5. I have a quick story that we're going to talk about with that in just a second. And then we have our biochemical marker, FFN, that will give us a very objective data about whether or not our patient is at risk in the next 2 weeks for preterm labor. So going back to transvaginal ultrasound, I was at a facility and I was doing a teaching on inpatient OB. We were doing an NCC, inpatient OB, and we got to the preterm labor section and we were talking about FFN and transvaginal ultrasound. And this hospital mentioned that they were not doing fetal fibronectin testing, and just as Dr. Ruma said, it is an 8 to 5 type of test. So I said to them, well, what happens to a patient if they come in preterm labor on a Friday night at 8 o'clock? And so they giggled and they said, well, they'll be here until Monday around 9 or 10. Is that not absurd, right? To have somebody have to wait around. This is 2023. Who should have to wait around for 3 days for a test? Right? It just makes no sense whatsoever when we could send an FFN and have it back in 38 minutes in the analyzer versus 3 days. And when you think about shared decision making, if that patient learned that later on that there was a test that could have been done, right, where they could have been in and out of the hospital in 2 hours. When you think about the inconvenience that created for that, think about if she was a nurse and she worked weekend option. That was her whole week. She had to take off a whole week there, right? To be in a hospital, hanging out, waiting on a test on a Monday morning. So we really cannot afford to keep people and stare at them, right? 23-hour ops. We're not really getting reimbursed just to wait on a test. And so cervical length is great. If you can have it in combination with your other things, right? The more information we can have, the better. Maybe when we're looking at a plan, but not something that we want to just be using individually. The other thing and the issue with it in the literature is if you have less than 15%. Dr. Ruma mentioned earlier about a patient 6 millimeters, 1 millimeter, the obvious there that, okay, that's going to be a patient that's at risk, a patient that has a length greater than 30 mLs, very, very low risk. But a lot of the literature, it's gray in the middle. We don't really know. between 15 and 30. It doesn't tell us a whole lot. So we still really need that FFN, right? We still need that testing to let us know about our narrowing in on that window of still when. The question still becomes when, the date when. And so we're going to need that FFN testing to be in combination. And so that was kind of some of the strengths and weaknesses. He highlighted some of that earlier, that, yeah, you know, it's great. We can visualize the cervix. He enjoys doing them. You have some MFMs that are really good at it. However, the weaknesses are if you do not have a good trained user, and most facilities do not have anybody 24/7 that is able to do this, it doesn't become so dependable and reliable of what we can use, like we said, independently. It's going to depend, like I said, on the equipment, the availability, again, that trained user, just, you know, and 30%, like I said, images may be assessed incorrectly. So he mentioned one as far as timing is concerned. It's a muscle. It could be the position of the patient during the contraction, after the contraction. There's so many different variations that, again, I can't emphasize enough how important it is to kind of have that collaboration because of that, of having your cervical length and your FFN testing, that we do really need both of those. And so what is our FFN testing? Again, our, you know, our glycoprotein here, our biological glue that binds that fetal sac to the uterine lining there, typically absent from the cervical-vaginal secretions from 24 weeks, and then it comes back as when the patient is ready for delivery. And actually, after 34 weeks, it returns as a lubricant that helps with delivery. We can assess patients for fetal fibronectin between 24 and 34 in 6 weeks, and our asymptomatic women between 22 and 31 in 6. So we want to make sure that we are doing our FFN testing. So like I said, anybody that is not doing that, please make sure you come to our booth, FDA test, only FDA test approved, and assessing for that. And so let's talk about the characteristics of a good test. So FFN, we've been talking about the negative predictive value, right, of the patient will not deliver within 2 weeks. I mean, and this is a really high, 99.8, it doesn't really get any better than that, right? 99%, it doesn't get any better than that. Another great thing that you can get from the booth later on is that we have these really, and you can get them online and they're free, they have these educational brochures that we even use at our facility. And they're very nice because they kind of help with customer service. As that patient is waiting on those tests to come back, it comes in English and in Spanish, and there's a little section that talks about, it reiterates what I'm saying. So they're not just having to believe you as the nurse, right? Because it's scary, I'm contracting, right? And I don't know if this is just my injury or my car accident from 5 or 10 years ago, or if I'm really gonna have this baby. This is scary to me, right? I'm 29 weeks and you're telling me that you're just gonna do a quick test and it's only gonna take 38, 40 minutes and then you're gonna send me home, right? And so that brochure reiterates what we're saying, that if you have a negative test, it means that you will not deliver, you know, over 99%. So it kind of gives them that reassurance where they're not threatening you to go to the next neighboring hospital. You don't know what you're doing. You know, I've been here, you know, a couple times and that kind of thing. So they know that they can kind of trust in the test. And like I said, it comes in English and in Spanish. And then it has a little paragraph in there for the positive as well, that if it's positive, we're going to come up with a plan. It's okay. You know, we're going to come up with a plan with that as well. So it provides really good education that the patient may need. It does not have a high positive predictive value because you can't have a test have it both ways, right? So if some of the, you know, your healthcare facility, you're finding that you have physicians or people that say, well, we're not using FFN because, you know, it doesn't really have a high positive predictive value. And so again, you can't have it both ways. I mean, the only person, right, that's going to know absolutely 100% for sure the baby's birth date and time, going to be Jesus, right? I don't have the number to the main line. I am in the Bible Belt, but I still don't have the number to the main line. So I'm going to continue to use my FFN testing until I know that direct phone number. I think 99% is pretty, right? It's pretty good. It's a rule-out test. And the other rule-out test that we use every day, our electronic fetal monitoring, right? Fetal monitoring is a rule-out test. Moderate variability, ACT rules out metabolic acidosis. So we use it all day, every day, and we depend on that. And so that's another really good rule-out test that we're using, right? And so like I said before, if you're not able to do testing right now, some of the other great things about our testing too, you can collect it even in the office. Your healthcare providers can collect it in the office. It can be in the refrigerator for 3 days. It can sit out for 8 hours, so they can test and maybe have a carrier bring it over if they need to the hospital. So, you know, we can really help you to kind of work through what testing will look like. We don't want that to be a barrier. I've heard, you know, you're at a teaching hospital and the residents like to do it, but then if they get busy, the patient sits, and so then we just go ahead and check them, and, you know, we don't get it because the nurses aren't checked off, you know. So we have a whole nurse ambassador program and things like that. So we've got really great nurses that can help you, free education, there's webinars, we have so many different things. And our reps, one other really nice thing over the years, I told you I've been speaking for Hologic for over 15 years, and we have some of the same reps. Do you know how nice that is when you think about all the products that you have, where we have certain products where we're like, who's the rep now, right? And you go through like 3 and 2 years, and it's really hard to keep up with who the next person is. So, it's a really reliable company. They really know their product really well. They've been with the company for a really long time, and they can come out and do in-services with your staff. We know we have that turnover kind of thing, and so if you're a leader here and you've got a whole new team, a whole new set of charge nurses, educators, reach out to them so they can come in and maybe provide some education again on collection. Doesn't hurt, right, to have an update on that in the morning and kind of catch them really quickly. So that's something else that you can kind of put on your to-do list of homework, of things that we can talk about later, or talk about with your reps. And again, these are the guidelines. We just want to make sure that we're not doing a digital exam, any kind of gels or anything like that prior to checking them. If they have had intercourse in the last 24 hours, something to note, a negative result is still a negative, right? It would just be our positive that may be a false positive, but a negative would still be a negative. So again, we may want to go ahead and do the test rather than observing them for 23 hours. Again, the patient may not want to wait that whole, 24 hours to wait. So the good thing is we can go ahead and do the test. And like I said, a negative is a negative. So I was mentioning earlier some of the, what are some of our barriers, right, to really having standardization? And again, we talked about being in a teaching hospital, sometimes larger hospitals. People are going in 1,000 different directions, no oversight, enforcement, the training experience. We don't have an educator right now. We don't have a CNS. We don't have anybody that brings best practice to the bedside. And so like we said, that's okay. We are going to be able to do this regardless. We're going to try to even work with AWHONN to get some guidelines and things like that going. And no established standard of care. Some of these can be all of the different barriers that you may experience, but we've got some ideas and some things that are going to help you. And one of the things that all of our organizations, and Dr. Ruma touched on this earlier, are in agreement with is standardization, right? This is one thing where AWHONN, ACOG, Society of Maternal Fetal Medicine, ACNM, on and on, all of our organizations say we need to develop protocols, that we need a standardized process, right? That those are going to be collaborative, inclusive. So like we said, in the middle of the night, it's a Saturday night at 2 in the morning, and you have a traveling nurse, she shouldn't have to go through a book of what this one likes and what that one likes, right? We're able to just kind of pull out the protocol or let her know exactly what it is that we have. We developed something like that we're going to talk about in a minute at our healthcare system with Platt. I mentioned WellStar, I work at WellStar, but March of Dimes and the preterm labor assessment toolkit, and to this day, we have a Platt protocol. So when that preterm labor patient comes in, we're able to assess her for, and go ahead and collect and send FFN, if we needed a UA and CNS, or, all of those things are kind of bundled for the preterm labor. If we need to get GBS, we have it all together so that we can move quickly and get that patient in and out of that triage area. So we'll talk about some ways of how you can develop those standardizations. And we know that they improve outcomes. We've had plenty of studies that have looked at, aviation and in the air, and how standardization, right, in our transportation and things like that is what keeps people safe. I used to have a little video that I would do in my nursing slide deck, and there was a little small TED talk on even just standardization of time. We didn't even see the benefit years ago of why we needed to have standardized time, despite the fact that trains were running into each other, right? It was 2:18 in Nebraska, and in California, it'd be 4:53, and people still didn't see why we needed to have a set time, and so it had to be standardized. That's where that Eastern Standard Time, Central Standard Time, so it took for that to become a law in order for us to see the benefit of standardization. So we know that we need to adopt that in the medical realm, and that when we do things the same, and when we think about even just with hypertension, right? Look at our rates, they're improving. We're doing better. When we think about that deadly deliveries that came out in 2014 and those grave outcomes that we got, and so when we, fast forward now, we've got protocols in place, right? We're giving labetalol, and, we know what we need to do. We're getting it done. We're getting it done within an hour. We're checking in on it. So we can see how QBL, right? We've got protocols in place now. We've got kits for our postpartum hemorrhage, and so we're seeing improvement. We're seeing improvement in our outcomes, and all of that was because of standardization and protocols. So we have some other areas where we can see that that's working, VTE, sepsis, right? And we can, go on and on. So these bundles and having these standardized processes are definitely going to be things that work. Now, as you go back to your healthcare systems and you're ready to implement some kind of quality improvement, what are going to be some of the steps? So some of the quick steps that we want to make sure that we do. One, be collaborative, right? Try to figure out everybody that needs to be at the table. So when we did our Platt we made sure to have the blood bank, right? We had the lab, right? Because the lab was collecting the FFN. You don't want to miss, you need to make sure you include them, right? So we had the lab there, staff nurses, right? Or maybe your chair of like shared governance, things of that nature. So do not forget to have the staff included in, and then variety of staff, weekend, day shift, night shift, right? So we want to be collaborative of that and including our leadership team, your chair, maybe of your OB, your, MFM. You don't have to have every single doctor, but just like a chair. You need a champion. That's it. You need one champion. So if you're working at a large hospital and you're thinking, oh, we have 300 physicians, it's really hard to get everybody, together, your supportive staff, you just find that one champion. When we went baby friendly, we found that one. When we did these projects, I was the lead for the postpartum hemorrhage project when AWHONN implemented that in 2014. And so I had my one lead. I had my anesthesiologist, that was my champion. I had my OB champion. I didn't go around and try to convince 55 doctors that we needed to do QBL, right? That would have been an I would still be trying to convince them, right? Years later, that would still be, I'd still be on step one. So just finding that one champion is gonna be good enough. And then make sure your hospital administration and things like that know what you're doing. Like we said, having your supportive staff. And do not also forget about your ancillary staff. If they're a part of your team and they're just like with QBL, if they're, gonna maybe put things on the scale for you or bring the scales in, or, if they're a part of the process, we wanna make sure that they're aware of it. Then training. We wanna make sure that our training is done, and that's where we can also come in to help and support having that training done at all different hours. So we can come in and, make sure, and if you're in the basic first steps of collection, and you need to learn how to collect the FFN, well, we can make sure to come in and spec training and, whatever may be needed. And then your data collection. Sometimes it doesn't have to be really fancy. Right? Data collection doesn't always have to be reaching out to the statistics people and figuring out. Sometimes in Epic it could be, or any of the documentation, Cerner, things like that, it could be a little bit challenging in figuring out how to pull some of that data. But the nice thing about our quality improvement project with Platt, this one was really simple to do because you really just pulled in the triage book. We just looked at the admissions, people that came in and complained of preterm labor. Pretty simple to be able to count that, right? And then the lab will tell you how many FFNs you're running. So even just starting with, let's see how many patients are coming in with preterm labor, and then are we actually collecting FFN? Let's start there and see what is our collection rate, and are we even good at that, right? And so that step one was pretty simple. Anybody can pretty much do that, right? Count in the book, kind of go through. So you can have a secretary, you can have somebody that's already maybe doing your MAG audits, some kind of, one of your charge nurses, you can assign them to simply do something like that, and then your lab will tell you monthly how many, like I said, FFNs you're doing. So the data collection does not have to be an arduous process. And then some of the components that you can kind of, your wheels can be turning, that you might be able to benefit from, that we can all help and support you with later. Is it algorithms? Like I mentioned, we had that lab order panel where we have everything that you would need for preterm labor already in a bundle. So we just click on it and it allows us to get, like I said, the UNA, CNS, the GBS if we need it, and the FFN, and able to send that. So by the time we're calling the doctor, this is what your result of the FFN is, right? That she's, she hasn't been contracting, she has been contracting. This is what her, vaginal exam is. So we have all the information that we need. Maybe it's some EMR reminders. Do you want any of those like little alerts, things like that? So just kind of be thinking about and having your wheels, like you see there, turning about what you might be able to benefit from. Dr. Ruma earlier showed you some of the ideas of different protocols and what they can look like. And so this was when we did the Platt project, and just think about, we saved so much money. This was 3 months in a short time, and we took 3 of our birthing facilities. We have 7 birthing facilities, and there were 3 of them that we used in this Platt project. And so we'll look at some of the benefits again moving forward, and some of the things that have really helped us with customer service. Like I said, patients don't want to come in our triage and be there for 6 to 8 hours. So having a standardized process and being able to just have that Platt panel, bringing them in, getting them out, so throughput, right, saving us an hour's time is money. This is labor and delivery, so we're actually paid for deliveries. We don't, unless you have an OBED, we're not really paid for, I lost my mucus plug. Here it is in a tissue, right? We don't get reimbursed for that. This is not like, labor and linger. We don't get paid for that. It's a whole nother, yeah. So anyway, so we need a protocol where we can get these patients in and out, right? Because sometimes we're talking about staffing and we're short-staffed, and not really, because we're staffed based on deliveries. So if you're being overburdened and overwhelmed with your triage, then this is going to be a way to help you, right? To have better staffing, because your staff is going to be distracted with taking care of triage patients that probably or may not need to be there. Like we said, remember, 50% of them go on a deliver at term. So patients that probably do not need to be there, right? So we want to be able to have these protocols to be able to help us to do that. And so this is one that Hologic has. So they have a couple different options of protocols that they can help and support and get you. And so also Dr. Ruma talked about our SFMM Special Society of Maternal Fetal Medicine special report, so we don't have to go into it again. We'll kind of touch on it. The highlights of it were, right, timing is everything. Right, so that's something else we want to coin and take that home, that with our steroids, timing is everything, right? Within 7 days before birth is optimally when we're trying to time this. Right now, as he mentioned earlier, only 20 to 40% of our preterm infants are receiving that within the 7 days before birth. And so this quality improvement metric and what this is going to do is really help us to ensure that we're giving it in the right time. Like we said, we know we can do it. We know we can give steroids, right? We had PCO3, so we know how to administer steroids. So now our next step here is making sure that it's in the time and in the efficacy window to ensure that it actually helps our infants, right? And so that becomes the importance of collecting our FFN. So as Dr. Ruma said earlier, we collect, we get our test, and at 26 weeks, it's negative. So it doesn't necessarily mean they're not going to deliver preterm, but not at this time, right? So we want to just try to improve on that efficacy window. And so this quality improvement project will really help us to do that. And we'll be working with our NICU. So this can be one of those kind of multi-unit quality improvement projects as well, because we're also going to be looking at maybe a length of stay in the NICU. We're going to be looking at how many of those babies went on to deliver at term, or babies that did go to the NICU that did not get them in the efficacy window, and looking at maybe the length of time that they're in the NICU. So this is something nice that your educators, can kind of collaborate with and partner, have your labor, your L&D maybe educator and your NICU kind of have almost two quality improvement, kind of projects going, and they're, looking and watching on their end. Can be part of this pilot and quality improvement in order to try to optimally increase the timing that we're doing things. So we're doing all the interventions, right, to improve neonatal outcomes. Raise your hand, everybody's doing this, right? We're doing steroids, like we said, we're doing MAG, right, for neuroprotection. We're doing tocolytic therapy for 48 hours if we need to, and we're obviously transporting patients. I'm also in a level 2 hospital, so we're doing all these things if we need to in order to get them. So this is just really fine-tuning what we're already doing, right? We're already just about there. So that last step is going to be ensuring that, and so like I said before, timing is everything. That's going to be our key of what we're taking away from this. Dr. Ruma kind of already talked about the benefits of steroids, so we know the reasons why we're giving them. And there is some concern, right? We're questionable as far as rescue doses. We're not sure. Like we said, neurodevelopment problems, pituitary gland shrinkage, and all those other things that have been thrown out there. So the fact that that information is on the table and that we've seen it over and over in various studies in various countries, why put our babies at risk if there is some concern? We don't know either way. And so again, with that timing is everything. When our babies receive their steroids in the right amount of time, in that 1 to 7 days, right, it's going to help us to reduce all of those respiratory issues that we talked about. But in that 8 to 14 days that Dr. Ruma talked about, that the longer we get away from the efficacy window, 5 times increase in the likelihood of the baby requiring intubation and advanced care within our NICUs. And so again, we're going to have the NICU end of that kind of track this, follow that, those days and how long those babies are in there. So this is really going to help us overall, right, to not only improve outcomes, but we talk about costs when we think about the cost of a NICU baby and their admission, their stay, separation from mom. It affects breastfeeding. I mean, so many different things, right? There's so many things that this can affect. So getting back to our quality improvement project. So this was our poster. So again, this is something that we'll be able to help you guys with doing a simple quality improvement project. And you'll see our nurses there are holding that brochure that I talked about. So come to our booth and we can talk to you about those brochures that are in English and in Spanish that you can hand to those patients, so they kind of have something that they're doing while they're waiting, that 40 minutes or so for that test to be done. You'll see there in the corner was our panel that we put in Epic that again allowed us to really quickly get that UA and CNS and send down that FFN if we needed to. And so it decreased our disposition time and triage by 40 minutes, right, by having a standardized protocol and not having to wait around and ask a doctor would he like us to send the test. And I think the other thing that helped that too, for any of the ones that were kind of lagging and still kind of rather wait and stare at them first for several hours, is that we all went on ahead and provided education to the patient, right? So we have a test that's here we're probably going to run in FFN. It's a test that only takes 45 minutes. So for those few doctors that didn't want you to run it, oh, I'm sorry, I've already educated the patient that we do have a FDA approved test that only takes 45 minutes. She doesn't really want you to look at her for 23 hours. I'm sorry. I'm sorry. Shared decision making is where we are in 2023. So the patient doesn't want to be here for the next 22 hours with us staring at her. She'd actually like us to send her FFN, right? And so, I mean, we've already collected it, sitting on a windowsill. Why wouldn't we want to just send it? She's okay with that. That's what she wants to do. Me and the patient would like to send her FFN, right? So that's what you do. Educate, teach your patient right when you get there that we have this new protocol, standardization to get you in and out of triage, and pretty sure this is what's going to happen, and we're going to call your doctor. So that's how you, get past that if you have a few doctors that don't want to send it. And then that'll help you to reduce your rate, again, of maternal admissions for false preterm labor. Like we said, we want them to, paint their coloring books and music and take care of Trixie at home, as Dr. Ruma said earlier. We want them to take care of their kids at the house. We don't want to have to come up with activities for them to do in the hospital because we're keeping people and staring at people that we unnecessarily need to have there. And then our cost savings. And again, in 3 months, $500,000 just in time, right? And nursing time and hours and looking at people for 7 hours, 8 hours, 23 hours. We won't have to do that. And we can have that space for that active labor patient that now doesn't have to labor in your OR because you don't have a place to put her, right? Because you have these patients that, just had a back injury years ago. Sometimes they're just going to contract, and it's okay. We'll do a FFN testing for them every 2 weeks, right? If that's what it takes, bring them in an hour and a half, get them a test, and back out of the door. It's something pretty simple that we're able to do, for those few patients that are just not sure. We can do that. So again, we go back to our slide. So if you didn't get a chance to take a picture of it earlier, I'm going to leave it up here for a few minutes now so that if you're interested in establishing a pilot or some type of quality improvement project at your institution. Come see us down at our booth. You can talk to us afterwards. You can reach out to us later. And so in conclusion, evidence-based, like we said, supports the use of FFN, cervical length for evaluation of patients in preterm labor. Standardization, we know it works, right? We know it works, and we want to properly time those steroids. And so let's do it. Thank you, guys.